right, good evening. Sorry about that, y'all. It's my bad. Well, there's a lot to go through airway management, but it's not like we haven't already addressed more further in some of the other chapters. As I put in the notes, please make sure y'all have printed out the NREMT checklist that's dropped on Navigate. I've also emailed it out, but that's very important because there's two. There's a medical patient assessment, and then there's a trauma patient assessment that you guys need to know. You need to learn them. Please don't memorize them because it's going to help you throughout your career. So just know that that's there. You will go over these when we get to a boot camp. So easier to know them early, as soon as possible. Start learning them because you have to know them to get out of the program. And don't forget, there's a boot camp coming up soon, as y'all posted last night. So that's another thing that we hopefully I can get home and make it to at least one of them before and meet some of you folks face to face. So we're going to dive into airway management. Come on, computer. I want you to, again, we talked about the physiology and the anatomy of the airway and some other chapters. We need to know how the airway is made up. We need to know, I'm starting this early. We need to know what we can do to put in place to secure the airway. So anatomy of it is pretty important as we move forward. So tonight we're going to go over airway anatomy, airway assessment, techniques for securing a patient airway, respirations, talk about those. Hold on. Let me go back and look. Oh, wrong button. Respirations, we're going to dive off more into the external, internal, and cellular levels. We'll talk about assessment management of adequate and inadequate ventilation, supplemental oxygen therapy, different types of oxygen masks. We'll go over. I have a couple of them out here that I'll break out in a little bit and I'll show y'all. If you don't know what simple mask, canary breather, and nasal cannula is, we move forward. Okay, know about that. So here's part of your anatomy. Let's get to know this. This one's going to be important. So when we talk about the nasopharyngeal, that is obviously the nose passage. That's not just your nostrils, but as the passage. So to do a little bit of teaching, I'm going to show y'all on the. Can y'all see my arrow? Is that right? Good. All right. So right here is where they run for the COVID test. This goes back into here, and this is where it seems like a long ways, but I promise you, I guarantee I've probably swabbed 3,000 people so far. So that's why it feels, if y'all have never had one done, or if you have one done, it's uncomfortable because your finger ain't supposed to go back that far when you pick your nose. So that's why it's very uncomfortable right now. They do in other countries, they do oral, they test, so it has to go back here to where it starts to make that upward and downward turn. That's just a little CYA, FYI. All right, so if you notice from the larynx up to the nasopharyngeal, that is what's broke down into the upper airway. A little bit of anatomy there. You break down the lower airway, bring the trachea, bronchioles, and the main bronchi, or the bronchioles, sorry. Where is my mouse? So down in here, you have your diaphragm. When I was going over things and I was telling y'all, C4 and 5 keep the diaphragm alive. This is the flexation of the diaphragm. So this is upon an exhalation. When it relaxes and goes down, you get an inspiration. Right in these little areas here, so bottom of the second intercostal, top of the third rib, this is where you would put your IO needle if you're doing a needle decompression. Just kind of some FYI, which y'all can't do needle decompressions, but your partners or paramedics potentially can. So when you break down parts of the alveoli, get into the alveoli, this is part of the brain stem. When we look at the ends of your bronchioles right in here, it breaks out to the bigger picture. So this is where we want oxygen saturation to go. This is where we want you to get to that 16% out of the 21 that you're breathing. And these down here need to inflate as fully possible. This is what gets stopped up with smoke over years, COVID, they don't regrow. So once your alveoli filled block, they die. They don't reproduce. So you're only born with X amount. and you move forward with X amount. That's it. So that's the reason why your airway is so important. I don't know about y'all, but I'm addicted to breathing. It's probably one of the only few things that I am addicted to. So I want to make sure I stay breathing. We talked about the anatomy of the respiratory system. We know that the system contains all the structures that make up the airway, help us breathe and ventilate, because that's a non-thought process. It is automatic. So we don't have to be like, okay, breathe, Chris. Exhale, Chris. Breathe here, because as some of us can't process just walking in a normal pattern, much less trying to think about breathing, blinking, or swallowing. So we know those. So I showed y'all how the airway is divided into the upper and lower. Hint, hint, that's probably going to be a test question. The talks about the airways up in there, divided into the, I call it the north and south of the airway. Oh, I want to go back and show you. So I was talking to y'all the other night about when we intubate as a paramedic, I'll put the ET tube in here, but now it doesn't go this far. So understand this is just a picture, but you see how the patient's right stem, majority of the time, is always bigger than the left main stem. So if the paramedic says, I'm only hearing right-sided lung sounds, they just need to pull back just a little bit, and then you're going to have breath sounds on the both. And the reason why is because that way that yeah, there we go. All right, so, and I'm trying to I'll block the airway if I push it too far. So if we pull it back a little bit, you should have both breath sounds on both sides. Yeah, I know that's a lot. I was just adding a little bit in there, my bad. All right, so we talked about that one. Let's talk about this one. We've already talked about that, but in some more details. Look at these 5 right here, and the nose, mouth, oral cavities, pharynx, and larynx makes up your upper respiratory. So what is the main functions? Hold on, that's not what I want to ask yet. I've got 2 different slides that I'm trying to go off of because I added to one and I didn't upload them in time to get them situated and get them mixed together. So that was all my fault. I'm having to go back and forth. So the upper airway's main function. So when we talk about warm, your nose hairs are doing the filtering. So everybody knows, everybody, I don't care, male or female, you got nose hairs. And that's what filters the oxygen, it warms it, and it does build humidifying capabilities because it's creating friction as it goes through the nose hairs, and that's what warms things up. Even though it's a cold environment, it's still going to warm the air a little bit because you don't want to shock your lungs as you're dropping it into cold air into your lungs. Yeah, we're still going to, I mean, cold air is still cold air, and you can't warm it up to what the body enjoys, but that's the part of it. The pharynx is the muscular tube. Hang on, let's look right here. No, that's the nasopharynx, sorry. And that's composed from the top to bottom, nasopharynx, oropharynx, and the larynx. Here's a picture of the nasopharynx. We break it down right here, coming in from the nose, this is coming in the mouth, and that is the larynx itself. So that's basically like right into here in this area is where the COVID's testing nasally, and orally it's going to come back in here and a little bit further in the back side of the wall. It's not comfortable, but I've COVID tested myself today twice just to prove a point. But, you know, again, we talked about that. The nasopharynx up in here comes into it. It's what filters out small particles. Now, your nose hairs is not going to filter out every single thing. That's why when we blow our nose, sometimes it's like, what in the hell is in my nose? Because your nose is all black. Well, that's because it doesn't filter out like it should. Well, it helps filter, but it's not going to filter out 100% of the particles. Let me move this so I can see it. So the oropharynx, posterior portion of the oral cavities, the epiglottis. This is a big part in here. And the epiglottis helps prevent food and liquids from entering the larynx during the swallowing. It don't stop it, but know that it tries to help it. So when the food goes down the wrong tube, that's because the epiglottis was not working like it should. But at the same time, as it did the best that it could. That's his job, is to try to prevent food and liquids from going down. So no biggie. Here we break down in the mouth. So look, you see your little hanky-danky thing, that's called the uvula. When we do oral, like if somebody's coming in to me and saying, oh, my throat's super raw, and you put the tongue dispressor down here and you're moving their tongue, this is the area that your doctors are looking for. They want to see if it's got the little white pus pockets stuck up in here. You want to rotate to the sides, and this is where it feels like you're like, because you can't get the tongue compressor. We're just not used to that. And then you can tell who has gag reflexes and not when you're checking them out here. You know, your tongue's just one of your strongest muscles in the world because you use it daily. It's your tongue. I think it's your tongue, your buttocks, and then it goes to the rest part of your muscles. And then your gums. So that's part of the breakdown of the mouth. So FYI here too. So if he has a basilar skull fracture, this is what's going to be broken, is your hard palate and your soft palate's going to be fractured. Now, when a paramedic or an advance goes to intubate this patient, you have to take caution, because if you're trying to rush and there's a basilar skull fracture right in here, the tube can go dislodged up into the base side of the brain, but that's rare. Okay, so when y'all hear, oh, the paramedic intubated the brain, yes, it's possible, but it's very, very rare. Here's a breakdown of your nasopharynx. There's your little hanky-danky thing again. Your oropharynx breaks down into your larynx. I'm not going to say that you're not going to see these again, but it may ask you what is located by the epiglottis. And you may have to go oropharynx and laryngopharynx, which should be pretty easy. You should not have any problems with that. As you can tell, I am wore out today. I've been up since 4, and tomorrow's another 4 a.m. day. All right, so the larynx, it's a complex structure. Whoa, Jesus. Almost lost it, girl. All right, so the larynx is a complex structure. It's all cartilage. You can actually poke through right here. So this is where I'm going to take a 14 gauge needle. If there's a mouth fracture, or I can't put anything in here, let's say, you know, when people have the little stomas and you see them, they put their fingers over it and they talk. That's a stoma. So a stoma goes right here. Yeah, you can breathe through it, and I can put the tip of an ET tube in there that connects to the BVM, if anybody knows what I'm speaking about, and you can poke a hole in through here and try to breathe. It is not easy at all unless there already is a stoma, because there's something wrong with all this structure is the reason why they have that. So, side note again, Tuesday night, y'all are gonna really hate my life, because the intro to pharmacology, I love it, and I will probably messed a lot of folks up, and I don't mean it, but airway is kind of the next thing, because there's so much that you can do and learn about the airway, and you still don't know enough. But I'm gonna go ahead and apologize about the Tuesday night, because pharmacology, y'all gonna hate my life. All right, so the larynx, all the cartilage is V-shaped, so that I promise you're gonna see that. You have V-shaped is cartilage. What is this? See here, the cricoid cartilage is a cricoid ring, is the first ring of the trachea, which is gonna be right here in this picture. And then the glottis, or the glottis open, is the area between the vocal cords. That is also the narrowest part of the adult's airway. Let's see, the vocal cords are white bands. So right here is these are going to be your white bands. So if you go to intubate somebody, and I'm looking right here, when I use the, I just went blank. When I use the blade to move the tongue out of the way, I'm actually looking for the white cords that you're going to see right into here. So this is the base of the tongue. You'll actually see the white cords, and you just kind of aim for the middle of it. It looks like a V, and you poke right in the middle of it. Intubating is very easy. It's very scary at the same time. So the vocal cords, we know, can be damaged. intubating of somebody, if anybody's ever had surgery and you get intubated, you're like, man, my throat really hurts a little bit because you may have had trouble when they intubated you or when they extubated you. They may have scratched your vocal cords. We also know, especially if it's your other half, special half, if their vocal cords get messed up and they can't talk, it's a great day. But that y'all tell them that, not me. So the glottis is the area between the vocal cords. So I just broke down the structure of the upper airways. What I want y'all to learn out of that is that all these different structures have very important meanings. They are important for us to worry about and know the anatomy. Let me see if my other document has anything that I want to specifically talk about here. No, I'll start talking more on this one when we get to going into hypoxia and all that. All right, yeah. 2 seconds, I done messed something up. All right, I'm back. All right, so here goes your anatomy of the lower airway. Let's see, hang on. I like this picture better. All right, so here you can see. Sorry guys, that's our, if y'all haven't learned yet, we on this rig, we have it called a Guytronics, and they think it's like a CD and they don't ever shut up. I'm the only one in the facility that hears this all night long, and even in my sleep, I hear him, and everybody goes by nicknames. Say, Catfish, come in on line 2. I don't care. So it's a pet peeve of mine. All right, so right here, this is your trachea, your windpipe. That's the area that we're talking about when you get punched in the throat, and you may hear somebody, oh, he damaged my windpipe. Well, yeah, because if you can crush it too, and when you crush it, you're crushing the cartilage. There's no bone in there, so that's all cartilage that you're going to be crushing. Here's your alveoli at the end, down in here to the bronchioles. You see, here comes in your main bronchiole. So this is your right main stem right in here. This is your left main stem. This little area right there is what I'm talking about. So then you have your main bronchioles on each side. That's where it branches off from your main stems. And then you come into your bronchioles that are further down. Here's your strands, and your alveoli are at the end of your bronchioles. Whew, I know that's a lot. I get it. But it's important that you know this, because if you don't do adequate ventilation, you're going to run into some trouble, because now you're not giving your patient adequate ventilation. And the problem that you run into is your patient's going to be hypoxic from you either underbagging, or they're going to be hypoxic from you ventilating too much. So yes, you can hyperventilate somebody with the bag valve mask or having the airway secured with an oral or nasal pharyngeal. That's the reason why we tell you, breathe. When you take a deep breath, bag the patient. When you exhale, let the bag loose. You don't want to be like, pull like a Bill Cosby on. I'm showing my age, but I hope y'all know what I'm talking about. Y'all seen that on YouTube. But you do have benefits of hyperventilating somebody when a paramedic's getting ready to intubate them, but at the same time, it's not good to continuously to hyperventilate somebody, nor do you want to allow them to be hypoxic, because if they're hypoxic, they do not have enough oxygen in their body. So that's the points what we want to push in there. So the bronchioles, they are made of smooth muscles. We talked about that. They dilate and constrict as oxygen passes through them. Your smaller bronchioles connect to the alveoli. It's the site of oxygen and carbon dioxide exchange. Just gonna say that'll be a test question. I remember seeing that one. Millions of thin wall balloon-like sacs are your bronchioles. Your alveoli are surrounded by blood vessels that is called your pulmonary capillaries. Oxygen diffuses across the alveolar membrane into the pulmonary capillaries. Oxygen in the pulmonary capillaries is transported back to the heart by distributed to and distributed to the rest of the body. Oh, love, you made me repeat which part. I talk a lot. Oh, you want the test question? I'm sorry. Let me get that back out there. Which I don't remember what I said. I know somebody remembers what I said. What I put. Samantha, I'm sorry, baby. I don't remember what I said. Which one is? My bad. I forgot what I said. Maybe it'll catch up with me. So the oxygen in the pulmonary capillaries is transported back to the heart and distributed through the rest of the body. So it's clean oxygen that's coming from the lungs to the heart that's pumped back out. Sorry, clean oxygenated blood is pumped back that's coming from the capillaries. All right. Carbon dioxide diffuses from the pulmonary capillaries into the alveoli where it is exhaled and removed from the body. And it's not in there, but remember, hold on 1 second, guys. They calling me. All right, I got a guy coming by to see me to get swabbed, so y'all gonna have to bear with me for a minute. We have to do 100% testing of our drilling people because we had a close contact out here the other day. So he was one of my last guys I was missing. So when we start talking about clean oxygenation and the distribution of oxygenated through oxygen through the body and the blood, so y'all understand it starts in the respiratory system and it moves. It's not like it's a smooth and fast process. It is slow, but again, it's knowing the process, knowing the routes, knowing everything and how it's transpired is very important. Because bam, look at this. Oh, that was not anticlimactic there. Look at this one. So you see air comes in here, comes through the lungs, goes back through the heart, and pump back out through the vena cava and comes in. Through the vena cava and aorta. So blood comes in and blood goes out. The mechanical mechanism of ventilation can be illustrated by using a jar, using a bell jar. So this is the 2 seconds, y'all. Hold on, he's here. All right. So when you put the body, the lungs in the jar, you're basically saying that it's inside. You have to do constrictions of the diaphragm, as you can see in the picture, that the diaphragm constricts, and that's how oxygen is moved through the body. Okay, cool. Sounds great. At least we know the process. Knowing which way the diaphragm goes for you to get oxygen in the body, pretty freaking important, because now you know the path of which way the path of the least resistance and how the oxygen moves throughout the body. So the biggest part is here is what's on this picture? Let's look. No, I'll break out my other chart in a second. All right. So media stadium contains, this is talking about the lower portion of the airways here. So let's get back here. So you have your heart, your great vessels, your esophagus, trachea, main bronchia, and many nerves. You're gonna get broken down. That'll start breaking down a little bit more. But knowing the different components, what's involved in the upper airway, lower airway. Potentially, you will see those on the test of which one is contained into what area. That's what we want to know. That's why I keep pushing about the anatomy portion. All right. So the physiology of breathing. Well, again, we know this is bringing in of new oxygen, getting away and pushing away waste products of carbon dioxide. That's the main important thing. You sometimes can have issues where you potentially are paralyzed and they have to put you on supplemental oxygen to produce because the drive is not there. So they breathe for you. It can be by ventilator. It can be by CPAP. Some other different areas that can cause some airway issues. So, but the main process of is bringing in oxygen to the cells and taking away the carbon dioxide. All right, pretty important too here. These three words tells you what the functions are and the definition. So if there's any questions, we'll go over ventilation. Is the physical act of moving air into and out of the lung. Oxygenation is the process of loading oxygen molecules onto hemoglobins and into the bloodstream. Respiration is the actual exchange of oxygen and carbon dioxide and the alveoli as well as tissues of the body. How's that sound? I know it's a lot, I promise you. Where's my, okay. I get my chat where I can see it. All right, so the physical act of moving air in and out is what? I'm making sure y'all paying attention to the reason why it says it on the screen, but
Inhalation.
what's the, see, at least somebody's awake, at least. No, I'm just messing with y'all. All right, so let's see here. Inhalation is the active muscular part of breathing. The diaphragm and the intercostal muscles contract during inhalation. This creates negative pressure within the thorax, which when you create negative pressure, air is automatically drawn in. So it doesn't matter if that's on anything. Let's say if you did that same thing to a balloon, created negative pressure, because when you blow it up, that's creating positive pressure. You're forcing air in there. So if you were to create a negative, like a vacuum, it's going to suck air, but the balloon is not going to inflate because of the process. But y'all picking up what I'm putting down, I hope. This next picture is, look, we'll just look right here. So the diaphragm relaxes. The mechanism of ventilation can be illustrated by using a bell jar, exhalation and chest contraction, and anomic left and the bell jar right. So you see, when it relaxes, air goes out. When it contracts, air comes in. Now let's see what they had to say on the second one. All right, so we talked about that. Oxygen and carbon dioxide both diffuse with the partial pressures in the air. That's a lot. That's confusing. I know. So inhalation, again, we talk about tidal volume. Now again, tidal volume does measure the depth of breathing. I don't foresee, and I know this is ugly, say that's super important in an EMS unless you're doing a critical care or a long transfer with a super sick patient. But most of the time, average tidal volume on an adult is 500 milliliters. Average child's 250. The same thing if you were to measure your back valve mass, they produce that amount of oxygen. So dead space is the portion of inspired air that fails to reach the alveoli. That is just because the alveoli are full. They can't take no more. It's like, I'm done. They tapping out and they closing the door. They can't do it. So that's what you get in the dead space. Exhalation. This does not require muscular effort. It is a passive process. The diaphragm and intercostal muscles do relax, which decrease the size of the thorax. The smaller thorax compresses air into the lungs in the smaller spaces. Ow. The air pressure in the thorax is higher than the outside pressure, and air is pushed out through the trachea. You know, you can do the same thing if you open your mouth. You can go through the exhale through the. It can escape through the mouth, but 99% of the time we're nose breathers unless you're a baby and you breathe through your mouth. They're born mouth breathers. They have to learn how to breathe through their nose. When we talk about ventilation, let's see, the body's need for oxygen is consistently changing depending on your activities. Your activities increase, so does your drive for oxygen. The body has to support that, so it's like, I'm about to die, so they increase your respiratory efforts. Your hypoxic drive differs from primary control of breathing in that it uses the levels of oxygen to control the breathing. Again, like it says right there, you typically do see that with end-stage COPD, cardio obstruction pulmonary disease, chronic obstruction pulmonary disease, sorry. Some believe that administering high levels of oxygen will increase the amount of oxygen dissolved in the plasma and negatively affect. It does not. It is always a consistent drive and need for oxygen because the alveoli are full, they have tapped out. When you talk about oxygenation, so that is the process and loading oxygen molecules onto the hemoglobin to the main bloodstream. So we want to fill them up. I'm gonna pull up my other one as we talk about. So we want to start oxygenating them, and we want to load that hemoglobin before it starts pushed throughout the bloodstream, so it's used in other places. I'm gonna talk about hypoxia for a second because I know that I don't know if it's coming up or not, but I'm gonna do this. So here, so hypoxia is not enough oxygen. Some of the causes of hypoxia is occluded airway. It does inadequate breathing, some shock, carbon monoxide poisoning, and diseases will cause hypoxia. Some of your signs of hypoxia include tachypnea, which is the increase of the respiratory rate. Dyspnea is the shortness of breath. They kind of present to you in that pale, cool, and clammy skins. It's just not cool. Their heart rate increases because their respiratory drive, their heart has to pump and produce more blood flow because it's got to produce more energy because now there's a respiratory issue. They do get very restlessness and agitated because, well, hell, you're taking my breathing away. What you expect me to do? Be all cool, calm, and collect, and be like, it's okay. I'll breathe in a minute. No, okay. You start to get confused and combative, and worst case you can go into convulsions, but that's gonna be as in like you're gonna be having a seizure. You will have a headache. If you've ever been to a low oxygenated area, you will notice that the oxygen levels are super low. So severe hypoxia, you some of the late signs of hypoxia is going to be cyanosis, and that is a bluish color around the lips. Remember the other night when I showed you a picture of the baby? That was hypoxia. They do have that altered mental status. They get very confused. They don't know what's going on. The biggest treatment that we can do is just open the airway and provide supplemental oxygen. Positive pressure ventilation is probably the best thing that we can do for them. Diffusion it's talked about gas exchange. Things diffuse from an area of high concentration to a low concentration. So in the lungs, O2 diffuses from the air into the capillary, and CO2 diffuses from the capillary into the air. So the body's just constantly taking it. The body does the exact same thing to the lungs, so they're changing. When it's time to take the CO2 out, it comes out from both. We'll go over that in a minute. I don't want to go there. Okay. We'll go back here. Let's go here. So the point I want to hear is the cells take the energy from the nutrient through metabolism. That is called cellular respiration. Each cell combines its nutrients and oxygen, producing energy and waste products. Maybe that's going to be the CO2 that you exhale or the water that you excrete from your body. External respiration, which is the pulmonary respiration, as you can see right here where it breaks it down from the capillaries into the pulmonary system. So you see where the alveolus is bringing oxygen in and pushing it up. And you can see the alveolus is taking CO2 out and it's pushing, the CO2 is coming up until here's where the exchange happens. See how in this picture this is more accurate. See how her right main stem's a little bit bigger than the left side. That's mainly accurate in most adults anyway. So I'll take, matter of fact, one of the guys out here is soon to be having a baby. He's going in Tuesday to have his little boy, and it's just a habit to talk about things that you're so used to. But I was telling him that most little white males, the OBGYNs want to cook those baby as long as they possibly can because they don't have enough surfactant. So the surfactant is what reduces the surface tensions and it keeps the lungs expanded. So if there's not enough surfactant, the lung's going to stick to the wall, the inside walls of the ribs. And it's not going to allow for it to have any, actually the lung's going to collapse. So little white males, they want to try to cook them as long as possible. They sometimes potentially will keep them 39, 40 weeks total instead of the rest of them you can bring, 37, 38. They don't really want to do anything less than that unless there's a big issue. And we get it, we understand, but it's safer for the babies to cook as long as they can. Sorry, a little tad note in there. Now y'all know about the surfactant. I'm gonna read some of the notes on this because this one's important. So the internal respiration is when oxygen passes from the blood into the capillaries of the tissue cells. Carbon dioxide and cell waste passes from the cells into the capillaries, and where they are transported via the venous system back to the lungs. Sorry, I have a guy flying out asking me a question. All cells, they need a consistent supply of oxygen to survive. Same thing. That's the same thing with us. For us to have a constant supply of oxygen, we got to breathe. Without that, we go into respiratory failure and we quit. Hold on 2 seconds, y'all. I got another one. All right, back at it. Sorry. So without adequate oxygen, the anaerobic metabolism takes place. So without adequate oxygen, anaerobic metabolism just can't function. the cells die, and you have to provide, like we said, it has to be enough oxygenation. That's the reason why our fight or flight method will kick in. You'll notice you'll be like, I gotta start breathing again. And you take yawns and deep breaths because actually, when you kind of do that throughout the day, what's happening is your body's recognizing that your CO2 level is a little high, and you're kicking your O2 drive a little bit higher. So you're trying to off gases and increase your respiratory rate because you need more oxygenation. Factors of the nervous system. We have our chemoreceptors. They monitor the oxygen, carbon dioxide, hydrogen ions, pH of cerebrospinal fluid. And the chemoreceptors, when serum of carbon dioxide or hydrogen ion levels increase, the chemoreceptors stimulate the medulla to increase the respiratory rate. And let me see if there's anything I want to add off the other one. No, not yet. All right. So when the medulla increases, what happens is it stimulates the Pons effect, and that's where the rate of and the depth of respirations increase. So the medulla recognizes that there's a lack of these, and if one of them's higher than the other, if the oxygen drops, the carbon dioxide's too high, the medulla kicks in, and then the Pons effect, and that's where you notice that you're breathing deeper. You'll see them. Some people just like when they relax, when they sleep, they take that real super deep breath. It's because the body's realizing that, okay, I'm relaxed. And then you start breathing normal. Like I tell people all the time, when people are like hyperventilating and all that, it's all right, bro. Just let them pass out. The body hits that auto reset button, ready to go. They back to normal. So the ventilation and perfusion ratio and mismatch. Ventilation and perfusion must be directed to the same place at the same time. Failure to match ventilation and perfusion is the cause of most abnormalities of oxygen and carbon dioxide exchange. I wish I could dive off into that a little bit more, but that part at the cellular level, Chris Welley don't get, bro. I don't get it. But I just know it says that you got to have enough oxygen for things to happen. Best I can tell you. So the ventilation, perfusion, we go a little bit further. When ventilation is compromised, but perfusion continues, blood passes over some alveolar membranes without exchanging of gas taking place. This result is in a lack of oxygen diffusions across the membrane and into the blood circulation. Stand by, let me see something. Carbon dioxide is not able to diffuse across the membrane into the lungs and therefore recirculates within the bloodstream. So it's just not cleaned. It's not processed fast like it's supposed to. It's the body saying, I'm full, I'm in drive mode, I need some more oxygenation. So it starts to pump it a lot faster. And then when it finally starts to perfuse correctly, that's where your exchange happens. When perfusion across the alveolar membrane is disrupted, optimal change of gases is prevented. Like I just said, it's got to find that normal hemostasis for things to start happening. When they exchange properly, it's on a, basically, like I say, it's a normal 8 to 5 job. Things are running fine. But when that customer walks in at like 450 and they want some help, and you're like, bro, that's when the body starts kicking like, okay, the pump's faster. Things are realizing that I need this drive, and something's gonna happen. Throws that curveball at you. Factors affecting the pulmonary ventilation. Oh, I'm just gonna have to tell you on this one because So intrinsic factors that can cause upward obstructions. Here's a big one. We already know that this infection is happening currently across the world right now. Infections can be pneumonia, RSV. These are some of the issues that we see currently in our state affairs due to COVID. It is COVID triggered because it affects where the body is already weak at and affects the respiratory drives till the infections kick in. Any type of allergic reaction is, we know that our respiratory starts being affected first. If you are allergic to peanuts and potentially are around something, you have those issues to where you're like, I can't breathe, starting to have trouble, everything's starting to close up. And that's where you need your epinephrines to trigger, open those alveoli, bronchiole, and your lungs back up. Nobody will trust they want to talk to you tonight, so hush. So you're unresponsive enough. You have your tongue obstruction. And again, you're not going to swallow the tongue. You're not going to like, oh my God, he's going to bite his tongue off if he seasoned. Yes, he will bite his tongue off, but that'd be about the only time the tongue is going to choke you. It will relax and cause an obstruction, but again, you're not going to swallow it and die from it. Some extrinsic factors of the respiratory is all trauma. Any type of trauma to the airway, crushing of the windpipe, an obstruction, any traumatic event that has blocked the airway is what we're worried about. Factors affecting respiration. So atmospheric pressure, partial pressure of O2. I can talk to you about the pneumonia and the pulmonary edema and COPD and emphysema because I don't really 100% understand the partial pressures of O2. I know enough about it to say I'm not going to do that because I don't know. Some of the internal factors, such as conditions that reduce the surface area for gas exchange and consistently decrease the body's oxygen supply. Ding, 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 pneumonia, because you're starting to fill with fluid. Same thing with pulmonary edema. Pulmonary edema will start pushing outward. That's where you get them cankles, them swollen feet, them swollen fingers, because you got a lot of fluid built up. And you got to take that fluid pill to get it off of you. Y'all know what I'm talking about. That fluid pill is Lasix. If you don't know that, but it's adapting upon how much. If it's a natural thing that the body produces enough fluid, you're going to be on a fluid pill anyway, and you're going to know. If you, let's say, if you tell me you take 40 units of it, I can give you 80 to try to get that fluid off of you one time. That's just something that we can do out here in the field. COPD and emphysema, you're going to see a lot of your COPD in your CHF patients, your heart failure patients, your smokers, your long-term smokers. And I'm talking about the ones that talk like this because they smoke for so long. We all know that guy, and I don't want to point and say girl, but we all know that voice. The man or female, they all got that same smoker's voice. Eventually, they gonna get this. They're gonna get this right here, and they're gonna get that smoker's pneumonia. And you may not see old Fred again because that smoking got him. 40 years of it, they finally got it. Some of the compromise that we may see is obstruction of blood flow to individuals' cells and tissues that can be related to trauma emergencies. The biggest ones here is a simple or tension pneumothorax. Open pneumothorax we can fix. Well, yeah, you can put a gloved hand over it, tape it down on 3 sides, consider it occlusive dressing. The hemothorax and the pneumothorax. Somebody tell me what a hemopneumothorax is. I'm gonna take me some water while y'all tell me what it is. Just Google it real quick. Some of y'all know. Come on. I know everybody's got their phone broke out, but like, I'm gonna look real quick. I'm gonna see. All right, since y'all all quiet, I guess I'll keep talking. So the hemopneumothorax, that's a combination of two. So the pneumothorax, which is known also is because if it's created by a collapsed lung, and that allows air outside of the lung. A hemothorax is when there is blood in the same space. So it's not, air is supposed to be in the lungs, not out of the lungs. Does that make sense to y'all? It's not supposed to be in that pleural space. Now, when you fill it with blood that's in that pleural space where the surfactant and the lung touch, that creates a problem because what you're doing is you're collapsing a lung. So, thank you, Rebecca. It's blood pooled in the chest cavity, which is a hemothorax. So the hemopneumo means you have blood and air trapped inside the pleural space of the lung. Maybe we taught y'all something tonight. If y'all just learned one thing from me. All right, some other issues that we have is blood loss. Obviously, we can only lose so much of blood before we start having issues of our own. Anemia. I hope y'all already know what anemia is. Hypovolemic shock and vasodilator. I'm gonna screw that one up. Y'all just read that one. I'm into making a fool of myself like I always do. We're gonna dive off into those because we actually have a whole chapter of shock. So I don't really want to like break this down out of when we're talking about our respiratory tracts when I know we have a whole chapter because I actually looked at that chapter today. All right, so going back over our patient assessment. I wish I could pull that up. Maybe I can. Let me see. Hang on 2 seconds. Let me see if I can pull this up. I'm going to pull up your patient assessment sheet and show you where you have to look. Obviously, my internet is slow tonight. Well, I can't get it to pull up. I don't know what the problem is. So, but if you will go back and take your time and look at it, your sheets have both, when you talk about patient assessment, and it breaks down what you do at certain times, how you do certain times. But there's a section in here when we talk about, I'm pulling it up another way. All right, let's see here. And then I'm going to slide it to the screen that I'm sharing so you folks can see it, hopefully. Or not, that's cool. So I'm going to show you real quick so you can't see it. Talk to me.
Are you referring to the patient assessment, the medical one, or the trauma?
Both. There's going to be parts in here where you, under your primary survey and resuscitation, it talks about assessing airway and breathing. You get 1 point to make sure you assure that adequate ventilation, and then another point for you initiate appropriate oxygen therapy. So there's 3 points there that you do the assessment as well. So you need a total of 42 points to pass this. Yes, you can pass without all 42 points, but again, I don't want y'all to do that. I want y'all to get all 42. If y'all will look at the very bottom of your sheet where it says critical criteria, I can't grade you because I'm your instructor. But if at any point in time y'all do one critical failure, you fail the entire station. I don't care if you walk in the door and you didn't even say you failure to take verbalization of appropriate PPE. Everybody remembers appropriate PPE: gloves, mask, and gown if possible needed. This time on apply BSI, proper PPE. Done. You've already done that. If you don't do it, you don't get to make those other 41 points because you failed. So when I'm telling y'all to remember these sheets and know them, you will start at the very top of the page. Every single one of these says takes or verbalize appropriate PPE precautions. That should be a free point. Even if you have it on when you walk in the door, you have to say BSI scene safe. So that means body substance isolation. My PPE is on, and then you say, what does my scene look like? Is it safe for me to enter? That is on every single skill sheet. I hope y'all are reading these. I hope y'all, promise y'all, I hope y'all are paying attention to these. They're very, very important. How long have I been going? I'm gonna stop here. Let's get 10 minutes because I don't want to dive off into this, and we'll come back. So see y'all in about 10 minutes. If y'all haven't pulled those assessment sheets out, please do so. All right, see y'all in a few minutes. Enjoy your 10 minutes. All right, we'll try to get back at this. I know y'all are so excited. All right. So when we go into our patient assessment again, so when we may end up realizing that we need to start CPR. You're Let me back that up. So when we start, no matter what, anytime it has to do with the airway or patient assessment at all, we want to wear the mask, protective eyewear. That it does nowadays includes the shields. Um, have all your airway management stuff at hand. Suction, airway tank, your airway bag, your supplemental O2. Um, and make sure you pay it. Now they're talking about your AGPs. I don't really hear a lot of I'm not used to the AGPs, but aerosol generating procedures. So as basics, you cannot give a nebulizer, but you can manage one as long as a medic has done it. They started the protocols, but anytime you aerosolize something that's going into the body, you have potential for aerosolation to come back. Yeah, we know we talk and breathe and function that particles do come out from our mouth / respiratory system. So we have that. Anytime that you do an endotracheal intubation, you take the risk of getting vomit, blood, any type of foreign substance on yourself. So yeah, that does suck. I get that, but that's unfortunately that's part of the job. That's the risk that you understand going into. Now, again, as a basic level, you may just be doing a OPA or an NPA, and those are just small check devices that you're going to hold in place. You may do the continuous positive pressure airway. So if you're going to be doing a non-rebreather, you'll strap that around their mouth, nose and mouth, and just monitor, make sure that it stays inflated and that they have enough oxygen all the way to the hospital. But let me tell you this, if you go to put them on a nasal cannula, which is little tubes that go inside the nostrils, when you go to remove them from the ambulance, unplug it prior to removing the patient, because you will pull their nostrils back to like the backside of their skull, because that tube can only go so far. Just saying, it may happen. May have done it once or twice in my career, but just be cautious. It's the patients don't think it's funny. So let me go back to my notes here on wrong ones. All right. So what is that? Talked about ventilation. So remember we talked about the respiratory rates between the children, infants, children's, and adults. Children's. Ha, you like that one. You make sure you know what their regular rate and rhythms are. You need to make sure that you auscultate the lung sounds so you can tell if they do have let's say they have maybe fluid in the lungs, or you want to make sure that they're clear is what I'm referring to. So if you auscultate enough to many lung sounds, you'll be able to tell which ones are sick lungs versus healthier lungs. Um, you make sure you know your adequate size of from the inspiration to expiration. And then when you talk about respiratory, so you want to make sure that when you breathe for them, that it's once every 5 to 6 seconds for adults with a pulse, 3 to 5 seconds for infants and children with a pulse. Your compressions have always stayed the same to 30 to 2. I want to make sure that I'm not going to skip anything real quick if it's going to dive off into something. We'll go over that. I'll leave that on that screen for a second so I talk about something else. So for the volume of the ventilation is set, so you make sure your effectiveness is there. You have your consistent, adequate tidal volume. What that's going to help you create is when you bag somebody, is that you have that adequate chest rise. and you want to, oh, hang on, obviously meeting got locked. Let's try that. Whoops. Sorry, somehow I was clicking around. And I locked the meeting. That's not nice. So we talk about that. So on your heart rate. So the heart rate returns to normal as long as you're doing the proper CPR and ventilations. Decrease in pallor or cyanosis, because what you're doing, if you're providing adequate ventilations, the color of the body is going to return. If that's effective. Now, if it's ineffective as you're breathing and you're doing your CPR and everything, you may have a rate that is too fast, which is going to cause gastric distension, and it's going to look like they swelling up on you and they bloated, which is not a good thing. I can promise you, because that air's got to go somewhere. And if that's the case, it will come up or go backwards and a poo. Just telling you, it's got to go somewhere. If you notice no adequate chest rise or fall when you're providing ventilations, that it may not be effective. You continue to see the hypoxic signs. They continue to stay blue. They don't change in a rate or a rhythm. And then if they're gonna become hypoxic there. Let's see, we'll talk about that in a second. So I did hit that. We'll talk about oral adjuncts, airway adjuncts in a second. I'm just making sure off the other notes that I've got everything touched. All right. So a patient may appear breathing after the heart has stopped. That is agonal respirations. Agonal respirations are not adequate enough for life. They will not work. You're going to have to do something. You're going to have to do artificial ventilations. You're going to have to start bagging or breathing for the patient. You go do CPR. Chain stroke respirations are often seen in patterns with stroke or head injuries. So you'll see from over the measure of 2 minutes, you notice how there's two big changes right there in that picture. So chain strokes go to irregular respirations, followed period by apnea, which is the squiggly lines, then it kind of gets flat, and then it goes really back to squiggly lines and goes back flat. That's where the flat period is where your apnea is, because they're not breathing adequate. That's how I found out that I wasn't breathing really well in my sleep after having a TBI in Iraq, that I quit breathing at night, kind of bad. So anyway, got that situated, I think. So you can see the change those situations that they can cause in different head injuries or trauma situations. So ataxic respirations are irregular or undefinable patterns. They will be from a serious head injuries. Patients experiencing a metabolic or toxic disorder may display other abnormal respiratory patterns. Kussmaul's is not adequate enough to support sustainable life over time, but Kussmaul's do perform rapid respirations commonly seen in patients with metabolic acidosis, which means they pH is off. They got to get their pH back so they can start breathing and not be in respiratory distress. Patients with inadequate breathing need to be treated immediately. Same thing you would want with yourself. Fix this because I can't breathe. I don't like it. I want to breathe normal. So the things that we can do without really, if you notice an airway management emergency, fix it, stop it, fix it. To do a head tilt chin lift. I hope 90% of you guys have all been through CPR, if not 100%. So you know what the head tilt chin lift is versus the jaw thrust. You can help them breathe just by doing a head tilt chin lift. If you have to supply supplemental oxygen, you can use the bag bowel mask without hooking it up to the supplemental O2. But it is better off to have 100% oxygen being pushed through that bag, which continuously. It's a continuous flow of oxygen. Ventilation support, which may require ALS care, where they turn around and do provide a endotracheal tube. Even though the patients may be ventilated appropriately, the adequate exchange of oxygen and carbon dioxide at the tissue level may still be compromised. So that's the reason why your medics put the finger probes on too, is because even if we intubate, we use another device we want to know what the CO2 exchange is. That's important because of the survivability of the patient. Same thing for firefighters and going to with house fires. We want to know, the department should have a policy of, 2 bottles in, 2 bottles out. Now, some departments may not have enough personnel for that, but what it does is it helps you allow for the exchange of carbon dioxide to take place like it should, because you're breathing through your mask. Yes, we know the Scots and all these other masks are made not to contain the CO2 and it's to be blown out, but you got to think you're in a toxic environment, that it is not only just for safety to do 2 bottles in, 2 bottles out, but during rehab, you should have your CO2 levels checked. And those can be checked also by putting the finger probe on to make sure that the proper ventilation is taking place upon your SpO2 levels, which that's all higher than that, than the basic level, but just kind of giving you some background. Let's see. So you can have high altitudes, which you can get, what is it? Forgot a particular name. People that climb Mount Rushmore and all that, they get altitude sickness, and it's because they get confused, combative, because of the drive for oxygen is so high and they need it, and there's so much pressure. Carbon monoxide is big. We have offshore, they have it, and working anywhere in the plants and all that, they monitor consistently for gases. So we do a lot of gas detectors out here, gas sensors, and anything confined space. They got to have all these precautions put up. But so poisonous gases enclosed in that. Any type of enclosed space should be monitored if there's not a confined space rescue that some of the fire guys may have some background in. Anytime you do trench rescue, structural collapse, or confined space, you should have a artificial ventilation fan put up that's piped in and out to the outside to help bring in fresh, clean air. That should also help in your knowledge of respiratory part there. When assessing your patient, consider for proper oxygen, which can be assessed by pulse oximetry, and that's what goes in a little finger probe. You have them on 99% of your monitors that are out there that are carried by ambulance services. Now, if you're on a basic truck, once you get out of here, your particular truck may not have one, depending upon your service. So it's very easy just to put one on the finger so you know what their SpO2 is. Oxygen saturation is a measure of percentage of hemoglobin molecules that are bound in the arterial blood. I want to know how much oxygen that is in the body and the blood. If it's working and you got 97%, that is perfect. I have a friend of mine, she's in the hospital right now with COVID that has affected her lungs, that her SATs are down into the mid to low 80s. Now, we were taught in school, anything that is 85 and below, you intubate. She is sitting at an 84 and she's talking to you. She's not intubated, but in the fields, if we have to, we can intubate at that level. That is not the normal SpO2 that you should see in an adult that doesn't have a respiratory issues. Pulse oximetry can take as long as 60 seconds to reflect changes in patient's oxygen. So if you put oxygen on somebody, don't expect it to take place instantly. It is a machine and it does take time for it to recycle. So be like, wow, what's wrong with my machine? Let me turn the oxygen up. No, bro, give it time to work before you do that. So the patient can develop respiratory insufficiencies well before the pulse oximetry works. Values begin to decline. because again, it's a machine. So you're either gonna improve fast and deep uh, get worse over time because you're counting on your machine and not your patient. So I tell you over and over and over, treat your patient, not your machine and your equipment, because your equipment can fool you and make a fool out of you. So end-tidal CO2, this is a little bit higher than what I would like to teach you guys, but it's in the national standard, so you got to have some ideas of it. So end-tidal CO2 is the measurement of maximal CO2 that is in the inhaled breathing. So a low CO2 level can indicate we show hyperventilation, decreased CO2 return to the lungs, reduced CO2 production at the cellular level. Um, so when you start to see very high numbers and you may have a patient that's in cardiac arrest, it's because you're ventilating too fast. It's okay to slow down. Now that you may have a maintained airway and you're breathing for them, you've got it secured, you don't want super high numbers. You want to be able to maintain that person around uh, whatever. I don't want to give you a number because I know your particular agency may have a preset number that they want you to stay at. So again, if you have high levels, you may have apnea to where they're not creating the exchange like they should because of the we showed y'all the when they bottom off and they quit breathing. So that's your periods of apnea. Again, that may be from sleep apnea. Just saying, I've been there. So your normal range is 35 to 45 when we talk about our end-tidal CO2. I have seen some agencies say that they represent 30 to 40. Other ones say they expect no matter what, you have to maintain 35 to 45. But again, that doesn't take into consideration that your patient may be a oxygen deficient patient anyway, where they're on home O2. So I tell you the national standard is 35 to 45, but that can change depending upon your agency. Let's see, can be used in spontaneous breathing patients with special nasal cannulas. So the end-tidal CO2, when you actually intubate somebody, you can actually put a little device on there that will measure it and will also give you your range of millimeters of mercury, depending upon your 35 to 45. So you don't have to really like dig for that, put a pulse back on them because it it fits on top of the tube that you ET tube them, and it's got a little device that runs into the monitor. It's a lot of wires when you start working cardiac arrest and you have ALS in there. There's a lot of tubes you have to be careful of if you all have never done that. So here, simple, very easy thing. Let me tell you, reminds you of your CPR class. Opening of the airway. If you don't suspect a any type of traumatic injury to the neck, you can do a head tilt chin lift. It can be just as simple as uh, adjusting the airway, and the patient goes, and they start breathing on their own. You may have to stimulate that patient and start breathing for them. If you suspect at all that the patient has had a traumatic event, even if you woke up and you see a man laying on the ground and there's a ladder, and you can just assume that he fell from the ladder. Maybe he was setting the ladder up and just collapsed down to his knees and fell back. You don't want to do a head tilt chin lift because you don't want to potentially compromise his spinal cord or his back. Here you will see, like, if they go unconscious, the tongue will actually sit back into the airway like we were talking about. But if you did the head tilt chin lift and got him back into this position, the tongue's going to automatically raise up. To kind of show you what I'm talking about, everybody's looking at your screen. I hope, I assume, maybe some of y'all are walking around talking and eating. I'm kind of jealous because I haven't eaten yet. But what I want everybody to do, if you can, look straight up to the ceiling. And what's going to potentially happen is when you do that, your mouth is automatically going to try to open. You're going to try to hold your mouth shut normally, but if you look straight up and relax, your mouth opens. So what you're doing is you're creating tension, and what that's doing is pulling your tongue away from your airway. Yeah, I know y'all are like, he's crazy. You don't know what he's talking about. I promise you, it works though. If anybody has any little kids, nephews, cousins, especially if they're not yours, do it when they're asleep. Tilt their head back just a little bit and watch how their mouth comes open. It's always funny on little kids that do it first because they're the first ones that go because you're opening their airway. They're not used to their mouth being open. Are you talking about the Rebecca? I just saw your message about the entitled CO2 in the veterinary clinics as well.
Yes.
Yeah, I did a little bit of canine medicine in back in my days. I can't tell you everything I've done, but I've intubated many animals and dogs when I was doing canine medicine. It's kind of cool. They have the same anatomy and airway as adults do, except you can pull their tongue super far when you get ready to tube them. It's
Oh
not
yeah.
like it's ugly or
You gotta be
mean. You just
careful.
pull their tongue
Don't
far
tear
out.
anything and cause bleeding from
Yes.
pulling the tongue.
The first time I actually assisted and intubated a horse, I was shocked that they were using like PVC pipe. Kind of scared the heck out of me. That's not what I was used to. So, but IVs on animals are a little bit more challenging. But entitled is the same way. And in any animal out there, same thing as adults, humans. It basically they do the same function. Their bodies, as long as they're a mammal, they function the same way that we do. Warm body, cold body, it doesn't matter. They still have the same hypoxia drive. They have the same hypoxia drive that we do, is that we strive for the oxygen. That's just what their bodies want. They need it. Either they're a fish or not. It's a mammal. Functions the same way. So you see here, we talked about the head and tail chin lift. I'm not going to harp on this because I pray to God y'all have already done this in some time in your career. If not, when y'all see us at boot camp, y'all are going to get it anyway. We'll probably do a refresher just because we want to make sure what everybody's level is. But there's the head tilt chin lift. Again, there's a picture and there's some steps. There's the jaw thrust. What I always like to do, and let me see if I can go back. So if you come up to this young man sitting right here on the screen, if he's unresponsive, he might be asleep, you don't know, but you start talking to him in advance. Hey man, how you doing? Can you hear me? What's going on, sir? Hey sir, can you hear me? You walk up. Now I'm not saying kick them, no, but make sure their feet make contact and be like, hey sir, can you hear me? When you get down close to this person, I like to stand at their head. I put my hand on their head like this picture is right here. I don't put my hand that close because I ain't got time to jerk. But you put their hand on their head because if for some odd reason when you touch them and they become responsive again, they can't lift their head up. Maybe they don't have a medical emergency, but you don't want them to jerk on you and they already have spinal issues. So put your hand there and be like, hey buddy, hey man, wake up, can you hear me? If you have to do a small sternum rub or mess around with their collarbone to create a little bit of painful stimuli, bam, there you go. That's what you want to do to try to protect the airway. Just saying, that's a Chris Wally little trick. So jaw thrust. The only thing we're not doing in this jaw thrust, oh look, there's a picture. The only thing we're not doing here is we're not rotating the head back to the flat portion of the head. If y'all don't know, yes, the skull is round, but there is a little portion back here that we can tilt you far back enough that your head kind of flattens out for just a little bit. That allows us to get to that flat point in their body. And the same thing is we can, on a jaw thrust, we can intubate here as paramedics also, but it's easier to do a head tilt chin lift where their jaw is up a little bit higher and the head's back so you can kind of see better. Because you got to get down to their level. So when they do throw up, you're probably going to wear it. So be careful. So here in this picture, you see them doing the jaw thrust. Initially, this is called the EC clamp method. These fingers make out of an E, and this right here makes out to a C. That is called the EC clamp. Just a tad bit, it doesn't tell you that, but you know, I have these old wisdoms that I like to pass on. All right, so here's some parts of your suctioning devices. This one is a hand operated. As you can tell, there is no battery, no nothing. And you squeeze, 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 and it takes a lot of squeezing to create a suction. And guess where it goes? In this little jar. This little line tells you it's full. Guess what you don't see when you're in a hurry and it's an emergency? That little line. So guess where it goes? It stops sucking. You gotta change that bottle out. Oh, I don't do vomit. There's a lot of things in my life that I will do. I'll deliver a baby over vomit. But this one right here can go a lot more. And guess when it's over with? Not Chris Wally's job to empty that. This this size container and this size container are the exact same on all your ambulances. Do you know why they did that? Anybody want to guess?
So they don't have to change it as frequently?
Save money. That's really
Save
all it is.
money.
So these two are the exact same thing. This is a Laridol suction device. But what they do is they interchange in the all suctions that are battery powered like this fit these containers. These canisters are bought nationwide, worldwide, and they all fit. 100% of your ambulances always have a suction device. So your portable suction goes out, you take the canister off, you put it in your truck mounted suction. That's it. You always got an extra one. Now you always should have at least two of these no matter where you go. Here's your suction handle. That's called a yanker piece. This piece right here goes in the mouth. You only suction for 15 seconds. You pull it out and stop. Take a couple deep breaths. Do it again. Suction the mouth. Don't ever go any further than what you can see. There's a little bitty tip right here that is open. Put your finger over it, and it suctions all the way back up this tube and fills that up. Nice, and that's all you hear. I know y'all like that little demonstration. All right, so a portable suction that can be crammed into a bag. It can be stuffed in certain places. Um, let's see, it is plastic, so be careful of that. They can dry rot. They do have rigid suction tips. So you see they have the anchor tip and the duocanto catheter. There's the two types of tips that you have on the suction. The large diameter plastic tips are rigid and they do not collapse. They're very, very hard plastic. It is used to suction the nose and liquid secretions in the back of the mouth. And in situations you cannot use a rigid catheter, non-breakable disposable collection bottle will be used. You want to use water, sterile water if you can, to clean the suction tip out. Oh, I hate suctions, man. Let me tell you, I despise them. But you want to open up a sterile water bottle so you can clean your suction out as you're going. And remember, be careful too, because if you suction up a lot of water, then you suck up a lot of food, you got a lot of liquid, and it's got to go somewhere. Did I just skip a whole one? So I highly, highly recommend you always inspect your equipment, because at any point in time you could need your equipment, and if you allowed yourself to rush and to not pay attention when you were initially at the station or wherever you were at, and you just didn't check your crap, that's on you when you get that call and it's broke and you're the one that looks like a dummy. So always check your suction. It is very, very important, and I like to do this. Turn your suction on. Put your finger over the little petcock tube hole and let it suck on your gloved hand or your skin for about 10 seconds or so. You're not trying to create a hickey, no, but you want to create enough suction and draft that it has some resistance so you can check your suction. It says right here, test the suction unit to ensure vacuum pressure for more than 300 millibars of mercury. There is a pressure gauge on there. A lot of them will show you, like you'll hear them. There's kind of like the motor going in the super drive. It'll be like as it goes to suction, because it's meeting resistance. So you can test them up to 300. Sometimes I'll like to redline them just to see if it's got the suction ability. and you're bored because you're trying to get your partner to check the rest of the truck and you just don't want to check it. Just telling you my tricks. So here it says never suction for 15 seconds at one time for adult patients, 10 seconds for children, and 5 seconds for infants. Hint, hint, hint. That will be important. Samantha, I'm gonna make sure I repeat that because I know I talked super fast the last time you said that. Never suction an adult longer than 15 seconds. Children should be no longer than 10 seconds, and infants should be no longer than 5 seconds. So I state that for you guys to pay attention and note that when it is time to move forward to a test period. I want to see how many slides we got left. I'm not tired of y'all. I'm just saying, personal knowledge.
I think it's about halfway through.
Yeah, I just don't know what number that is. All right. Oh, well, we'll keep going. All right. So anytime that you,
I was just saying, I think there's like 120 slides, and this one is like 65.
Yeah, we're up on 60 something.
64.
Yeah. So suctioning tips, always make sure you grab the right one. You can have soft tips and hard tips depending upon what's needed the best. Any type of secretions that are in the patient's mouth you want to remove, because if you don't remove them, they're going to be airway obstructions later on. There may be times that where you get a patient that has just had their face punched in and maybe you just need to suction teeth out, and it's not inappropriate to allow a patient to hold the suction of their own. If they're bleeding profusely in their mouth, you got a ton of other crap to do. So it's going to be okay to allow them to be like, hey, bro, I want you to put your finger over this little tube when you need to suction and or spit, like going to the dentist. Put it over here, close your mouth, and it'll suck it up. When you're done, open it up, let go of the little tube. Got it? All right, be right back with you. Sounds like I've done that before. It's okay. But choosing the correct tip is the most important part. Anytime you suction, you don't want to do it back to back, like 15 seconds, stop, 15 seconds, because you're not providing enough oxygenation to the body. It says in there, do for 2 minutes. It's like a 2 and 15, if that makes sense. You want to breathe for the patient for a full round of 2 minutes, and then you can suction for 15 seconds. Because remember, again, if you have that patient on a pulse ox and you do suction for 15 seconds, by the time that it registers and you get the patient back on, you're gonna be like, oh my God, they're bottoming out. I need to, do ventilation. Well, hang on there, cowgirl. It might be because it's the body's adjusting, and now that it's just reading through the pulse ox. So let it all equal out, give 2 minutes, and look at it before you start doing things. What's that say? Continue on secretions are cleared. Yeah, continue to suction until the mouth is clear. That may be, like I said, an ongoing process. The patient's awake and alert, and they just have profuse bleeding. I picked up a guy, bro, my last time to work on the ambulance, I remember this specifically. A guy called because he had bleeding from the mouth, uncontrolled bleeding from the mouth. And I'm like, it's 2:45 in the morning. What the hell? Well, I felt so bad because it was like an 85-year-old man. Then I felt like an idiot. But he had mouth surgery and just couldn't get the bleeding to stop. But he had been bleeding since like 8 o'clock. So it's like, bro, let the fat guy sleep. Come on now. But I gave him the suction canister and the tube, and I was like, hey, man, here you go. You know yourself, so just suction it out. There you go. Because, I was trying to get some other things done, some IVs done, and he was able to talk. He just couldn't stop bleeding. So proper tips and easier suction and a little bit of education, and he was able to rock on by himself. So basic airways. We talked about the oropharyngeal. You can use these for, let me back up, see what it says. So oropharyngeals, it does, oh, I hope there's a picture in here of them. It's not. So what it is, it's a device, it's a little tool that goes into the mouth, and you measure it. You measure the oropharyngeals from the tip of the earlobe to the corner of the mouth. That is about the average size of each person. You can take your thumb, put it at the base of your ear, and then your pinky and put it on the corner of your lip, and that's about the size that you need. Now, what they do is they do color code them, so it is okay to bring them out, and they are individually wrapped majority of the time. And you can turn around and say, okay, look, this lady's gonna take a purple. This guy's gonna take a green. Well, that's fine. You just gotta know that. But if you don't know it, just measure them. It's cool. For a nasopharyngeal, you go from the tip of the nose to the corner of the earlobe, or to the tip of the earlobe, sorry. So it's just from one nostril to the other, and you always want to go down the right nostril first because it's always the biggest one. Oropharyngeals do keep the tongue from blocking the upper airway. It does assist with suctioning. There are grooves cut into the side of these oropharyngeals that you can also run the soft tip catheter down into the mouth and do a little deep suctioning once in a blue moon if noted and does require. You can't do it just for fun because the patient pissed you off, because that is not what you're supposed to do. Just saying. So some indications. So an unresponsive patient without a gag reflex, you can put in a oropharyngeal. If they do have a gag reflex, hope everybody knows what I'm talking about by gag reflex. They just don't allow certain things past a certain depth in their mouth. A lot of us happens. I'm weird. I'll tell you something about me if y'all don't know I'm weird. I gag every single time I brush my teeth. It ain't because I'm gagging myself. It's just I can't handle it. Ugh. But I'm very, like, I brush my teeth 3 times a day. So I'm pretty adamant about that, but I gag every single time. Anytime that they are unresponsive and they don't have a gag reflex is cool to put one in. Apneic patients with being ventilated with a back valve mask, it is very good to go ahead and secure the airway. These can come in and out if they're unresponsive. You put one in. If they start to come responsive and they start to fight it, take it out. No big deal. Some of the contraindications are conscious patients. People don't like that. And a patient who has an intact gag reflex. An oral airway is too small and could block the airway directly, like an formed by obstruction. If you encounter a difficulty inserting the oral airway, an alternative method may be used, inserting it to a 90-degree and rotating it. If you look in your books on 11.5, it shows you the diagram and how to do that. It's a little curved. It kind of makes like a C. It's like has a little fat tip, straight, and then it has like it's called the shaft, and it dives off into a C pattern. I don't know why they're not in here as pictures. I apologize. If I would have noted that, I would have inserted pictures myself and would have had some pictures in a video, but can't help you out there. So a nasopharyngeal is used in patients who have an intact gag reflex but is unable to maintain his or her own airway. So there's 2 ways to get to your airway, as we know, because it's part of your upper respiratory system, is the naso and oral. So we can dive off into them, basically. If they gag, and they're unresponsive, they'll gag, you just drop a nasopharyngeal in there. But when you do this, please use the little baggie of KY that is also put in there, because you need to lubricate this. Because you have to remember, some of these things are very large, depending on the size of the nostril and how far it is that when you measured it, that they need some lubrication. Now, if you're in a situation when you're very far out and you're out in the middle of nowhere and you don't have any KY, well, guess what you can do? You can open up the patient's mouth swirl it around and get it sloppy with spit and put it in their nose. It's their body substance, not yours. Not that I care about it, but it's theirs. We can use theirs. Um, it does help maintain an airway. Now it's not going to keep the tongue out of the way, but what it does is it pushes it to the side. You go down through the airway and it goes straight past the tongue. So if they are relaxed and they're blocking the airway, you can do a head tilt chin lift and it opens it pretty drastically. Like we said, when y'all looked at the ceiling, and that nasopharyngeal is straight back there and you're going to provide a good airway system. Some semi-conscious patients may take it, some of them may not. Let's just say patients who otherwise will not tolerate oral failure airways, you can put them in there. We talked about this earlier when I was telling y'all about the basal skull fracture. They say it is a contraindication to use these if you see blood draining from the nose. History of fractured nasal bones. I can say it, don't use them because they have deviated septums, which is going to create some resistance when you go in there, and it's very, very difficult to intubate somebody that way. I'll just here. Well, you should know this from your CPR classes. Use them in the recovery position if they're a unconscious patient who is breathing on their own. You want to put them in the recovery position. And as y'all know, hopefully y'all learned this in your CPR class too. If you see the way the young lady's laying, she can't roll any further over onto her stomach, which would be impeding the airway because of the way that the right leg and the left arm are placed. Because what it's doing is it's stabilizing that patient from coming further over. The hand is underneath the head to protect the head. Plus, if they do vomit, there is a gap between the ground and their face. So because the head's laying on the hand. That makes sense to y'all? I kind of hope it does because y'all can see in the picture. I don't know how well you can see in the picture, but that's that. Always, I'll tell everybody this, give patients oxygen no matter what. Now, I'm not saying if they call you because of toothache, you want to put them on oxygen. No, but O2 is cheap, it's easy, and it's the cheapest thing that you can provide on your ambulance. The most expensive thing is literally driving them to the hospital. But never, ever, ever, ever withhold oxygen from a patient who is going to benefit from it. If they ask for it, so what? Just give it to them. It's making it easier. I promise. Because now that patient's like, you and that patient have a little bit of rapport that they're allowing you that they asked for something, you gave it to them. So if you think that the giving them oxygen is going to make it better, oh Jesus, just give it. I promise you, it'll make your life a lot better. So oxygen cylinders do contain compressed gas. There are different size cylinders. Most size cylinders that are inside the ambulances are D seals or the jumbo D cylinders. I just went blank of what size it's in the like your O2 bags, but most of your D cylinders are the ones that are in your ambulances. Oxygen cylinders will last at different lengths, and so your truck system is going to last obviously longer than your portable O2 bottle because of the different volume of air. Now they're going to potentially have the same pressure, but the volume of O2 and the D cylinder versus the portable cylinder is based off of volume. So if your paramedic intubates somebody and puts them on a ventilator, you have to hurry up and get to the ambulance because you're going to run out of portable oxygen. Just automatically know that. I don't care if you break the seal on the oxygen as you're putting the patient on the ventilator, you're going to run out of oxygen until you get to the truck. So you might as well bag them and then put them on the ventilator once you get to the truck. I see where it says liquid oxygen is becoming more commonly and used alternatively. I don't know of any services that are using that in the state of Mississippi. I know some parts of Georgia does have nitrous on their trucks that they can provide O2 and nitrous. Uh, I don't. I'm pretty sure that nobody in my state can do that. If they do, more power to them, because I would like some of that nitrous myself. No, I'm just kidding. But there are different benefits. So as you can see, what it's showing you about the liquid nitrogen. Go. You always want to be safety when you're dealing with these O2 cylinders because they can be explosive torpedoes. If you accidentally drop them on the tips and the valves are sheared, the O2 is going to flow out at a high rate of PSI and use that bottle as a projectile. You've all seen the videos where the O2 cylinders, the head was sheared and the cylinder shut off like a rocket. So just remember, if that happens and it hits you, it's going to severely hurt, if not deathly causing. And they can happen also in heat, car wrecks, and things like that too. So most of the time when ambulances are transporting patients, that the O2 cylinders are stored in the upright position. So if something does happen and you get in a wreck, it's going to shoot downward towards the ground versus laying it flat underneath the seat or against the sidewall. It might go out the back of the ambulance or into the front of the truck where it could cause more damage to the care provider or the patient. So you're going to see them 99% of the time transported in the upright position. It may be at a 40, 45 position, depending on how the truck is made. Let's see, pin index. I don't know much about that one. All cylinders they've gotten where they have the standard. I forgot the standard name. I actually knew it, but there's a standard for all medical grade oxygen that it has to have a certain type of tip to where all your regulators can fit on it, and it's very common throughout the medical field. Same thing at the hospital, that they use different size tanks. So, because you got to think they're pressurizing a hospital, not just a small ambulance. But it is, the cylinders are all maintained underneath the same standard. Pressure regulators. I don't know much about this. I actually didn't even learn this. I've learned it over time going to some different schools. But the pressure regulator reduces the cylinder's pressure to a useful therapeutic range of 40 to 70 psi. It's not as forceful as you're using like a non-rebreather into that situation. But they do have a quick fitting female connection at the flow meter, and that hooks up to where it's a faster and more secure way when you hook this device up and it's connected. Flow meters shows you the pressure that's inside the bottle. It also shows you the pressure that is being given to the patient. So you may have a 2-in-1. You 99% of the time will not have an electronic one, unless you're inside the ambulance, but it's still a flow meter. It's just a little different. You do have the board-on gauge flow meter, the pressure compensated flow meter. On your portable ones, it's easier and cheaper for them to do the pressure compensated. So when all the pressure is bled off and the bottle's turned off, that it shows 0 on the gauge at all times. Your board-on gauge, if I'm not mistaken, even if the bottle is turned off, it still shows you bottle pressure. They're just built a little different. Obviously, there are hazards with supplemental oxygen. We know that to have the fire tetrahedron, you have to have oxygen heat and fuel. Well, this has its own oxygen, so if there is fuel around, it can aid into the fire, as long as those three are there to formulate the said firehead to T-dron, and you can have a pretty large its combustion. They talk about oxygen toxicity. Now I'm gonna tell you, as long as I've been with patients and transporting, I don't care how long I'll give them oxygen for how far, you're not going to provide them enough oxygen for them to be into that position. Even if you have them on 15 liters of non-rebreather for hours, like let's say 5 hours at a time, it's not going to cause oxygen toxicity. It can create some balance issues when you talk about when you talk about hyperventilating a patient, but you're not going to see a whole lot of change like that into the EMS role. We know we've all seen the combustions when oxygen does not burn or explode, but it does speed up the combustion process. We don't want it to be around a fire. Never leave oxygen cylinders standing unattended. If you change a portable O2 bottle, lay it on its side, because if it does fall and it accidentally shears the head off and it becomes that projectile, it's embarrassing and it could harm somebody. So don't let that happen on your watch. Not all patients need high concentrations of O2. We talked about that. When the pulse oximeter is available, tailor oxygen therapy. Make sure oxygen stats stay above 94. The International Liaison Committee of Resuscitation guidelines published by the American Heart Association recognize there may be negative effects of oxygen toxicity and recommend that oxygen be administered to patients experiencing signs of myocardial infarction when they have signs of heart failure and room air oxygen saturations are less than 94. Just give the patient oxygen. That's what it boils down to. We're not trying to do a study in the back of our ambulance. Just give them the oxygen. I promise it's gonna be okay. We talk about oxygen delivery here. Look, we're gonna talk about these. So this is your non-rebreather. At this end is your bag. You always want to make sure that you hook this up to your oxygen first. Turn it on to 15 liters. Put your finger over this little bitty valve right here. Fill your bag up prior to attaching it to your patient. That is the right thing to do. That is the correct thing to do. Any other way, if you don't fill this bag up and you put it on a patient during a skill, you will fail. If I was grading yours, I will fail you because that is neglect. Period. Sorry, I just had to add that. Make sure I understood that. All right. We just talked about that. If you stop the oxygen therapy, the last bullet is very important. Don't leave the bag on them. Remove the bag from their face, because guess what? If they're not gonna, suffocate, they sure ain't gonna like you when that thing starts sucking to their face. So it's important when you stop, remove it. They do make adults, infants, and pediatric sizes. A lot of the time in the children's, you're going to be using the blow-by method, which means you're going to allow the parent that's riding with this child or yourself to use high flow O2, but you want to just hold it close to their face, so it's blow-by, and it's trying to stimulate them to breathe. This is a nasal cannula that I was talking about. You may hear it nasal rockets, rocket cannula. I've heard it all different things. But if you notice, this tube is pretty long. This tube does stretch. And when that's connected to your truck oxygen and you try to remove the patient without removing that from the truck, you look like a big old dummy, because they're going to laugh at you. So the biggest thing here is your non-rebreather flows at 15 liters a minute. The nasal cannula is 1 to 6 liters a minute. That's important. It states that it can provide 24 to 44% inspired oxygen. We don't use that much, so we're going to blow it off. But it's important that it's there for oxygen therapy and just the care of your patient. If you had them on 2 liters nasal cannula, which is nothing, and the patient's like, man, I feel so much better. That's amazing. You know what? You have saved the day. Woo! Let's rock on. Simple things like that can make or break you. Even if somebody says at home, they're like, well, I'm on 1 liter of home oxygen and they have a 50-foot freaking cord. They don't have nothing coming out the end. For all you firemen out there, think about the friction loss at 1 liter and a 50-foot hose. Well, let me tell you, that's a waste. But I don't say nothing. I'll pump it up and we ride on. Use of nasal cannula in patients with mild hypoxemia. Always start with a nasal cannula in somebody that can walking, talking, and breathing. It says they can't breathe. Don't ever put a non-rebreather initially on the patient, because you can't get any better than that. So if you start them low and you work your way up, maybe has been a respiratory issue that you're able to work with and fix due to that, but you start low, work your way high. Now, if they desire and they are having a respiratory distress issue, give them the non-rebreather, skip past the nasal cannula. You do have partial rebreathers, which this is a partial rebreather. So this is what's weird. This machine delivers 24 to 40% of oxygen by changing these out right here. So these are oxygen, these are different percentages. So if somebody needs a certain percentage, like this one is up to 40, and they break them down, this one may be 40. I don't know the color code because we've never had the color code. But you just change the tips out and you're changing the oxygen concentration of delivery. If you notice there's no bag right here and there's no one-way valves on the inside, it just blows out from the nose cup right here, and that's the way that they get their oxygen. So at the same time as they may be getting high flow, but these with having no one-way valves, a lot of return oxygen is going back out to the open. So patients with tracheostomies or stomas, they do have certain type of mask that connect to that, but you can also use your non-rebreather mask. You can have a stoma mask, but this is just a non-rebreather. You can attach it to the straps around the stoma that hold it in place, or you can put the complete plastic around the patient's neck and let it hold to the back side of the neck. It's just whatever suits easier, but know if you hold it there, now you're stuck to holding it the entire trip. So you may have to figure out some way to secure it, because I promise you're going to get tired of standing there holding that thing. Trach mask, not all available in emergency settings. They do improvise by using face mask and trach openings, like I was telling you. You can attach it just any way possible. Assisted artificial ventilation. So what's this going into? Remember, we're starting to provide supplemental oxygen for somebody. Now we're aerolizing things. So when we go to aerolize from a patient, we have to be careful because we need to make sure that we have some type of respiratory protection on, because now that we are pushing what that patient has potentially out to the open. Sorry, my company's emailing out about a COVID question. All right. So make sure you take the precaution measures when you do any type of ventilations. And it's okay to wear the mask, but just make sure that you say, hey, BSI seems safe. I do have a mask on for protection. At this point in life and stage, that is probably going to be the new standard for quite a while, from what I understand, but we may be stuck in this mask system for a while. Signs of symptoms of inadequate ventilation, they don't look no better. That's easiest to say. They just don't look no better. You know, when you look at somebody and be like, oh, he looks bad. Everybody knows, you have an idea that that patient looks like crap. But if you provide correct ventilations and you make sure that their ventilation procedures are done appropriately, guess what? They're gonna look better. They're gonna come around more. Hey, how long have we been going? I don't even know. I forgot to reset my clock. How long have we been going here? Anybody?
Since about 6:45, so a little over 2 hours.
Oh, Lord, let's take a break. Oh, let's take 10 minutes. I wonder, I'm getting antsy sitting over here. We'll stop right here and take a quick break. Give y'all 10 minutes. See you in a minute. All right, we're close enough to get back to starting. We're not that much further from being done this evening. Plus, we're going pretty quick, so I'll probably. I don't know why I can't see that, but it'll be all right. We'll get there. So, we talked about that. We'll keep going. All right. So, assisted ventilations. When you start bagging somebody, it should be very easy. You want to do the same mechanism as you do the head tilt chin lift. You want to use the EC method because you want to be able to hold that around the bridge of their nose. You also want to ensure the seal is good on the chin, bottom of the jaw. So it's important to have that EC method done on there. That's something that we will show you a couple of times in the boot camp because we want to catch you up to where you're at, your skill level. Continue on so you don't have to wait to the end and everything's done and everybody forgets. So when you do this, your initial, you want to, when you put it on there, you want to do like a rescue breath. I know you learned that in CPR. So when you put it on, you should not meet a lot of resistance. But if you meet resistance, do a head tilt chin lift again, and maybe you can open the airway that way. You want to squeeze the bag slowly and completely each time you breathe for the patient. Again, the faster you breathe doesn't mean the better off ventilated that they are. You're just hyperventilating them, and that could lead to inadequate perfusion. It's not good. So that's a big deal we don't want to do. You can do the mouth to mask technique or 1 or 2 person bag mask. Let me tell you, folks, I am not a fan of the mouth to mask or mouth to mouth. Unless I know you and I live in the same house as you, we ain't doing no mouth to mouth. And very limited on mouth to mask, even though it's got a one-way valve and it's going to prevent things. Nope, not happening. Chris Wally says, no, we're just going to do some CPR in for you, not no ventilations. I can't do it. So you can do 1 to 2 person bag valve mask. It's basically the same. One person holds the mask in place, the other one just ventilates, and you rotate out. It's just like having multiple hands to do CPR. You have 2 to do ventilations, 2 to do CPR, and all 4 if you rotate. It is a lot, does get crowded, but more hands are better when you break down to start doing CPR. I promise you. The more the merrier. I won't turn anybody away. So normal ventilations versus positive pressure. So let's think about this. So the thing that you want for positive pressure ventilation, that is forcefully forcing oxygen into the body. Now, the positive pressure device, it has a little valve that sits on top, and when you it pushes oxygen deep into the body. So it's not as I don't like them. I know a lot of them aren't used in the South, but it has its time and place. But in EMS, I'm not a fan of it. So versus normal breathing, it allows the diaphragm to contract for negative pressures is generated. But positive pressure is generated by it's forcing the air into the chest cavity. So you could rupture the alveoli or the bronchiole or the capillary. So you have to be very, very cautious about the timing because you can also hold down that button and it continues to force air. So you have to have training and use of the pressure device. So with positive pressure, the biggest thing is I want to go over here, besides what's on your screen. Ventilation rates for an apneic patient with a pulse. The adult is 1 breath every 6 seconds. The child is 1 breath every 2 to 3 seconds. And the infant is 1 breath every 2 to 3 seconds. That to me is the most important part for y'all to understand on ventilations. Now, again, they do make each group's own bag valve mask. So use the one that fits that patient most appropriately. It's the best way I can tell you for that. Now, if you're using the bag valve mask and you do it, you're trying to hyperventilate the patient and you feel resistance, you can force air into the stomach. And I told you before, that's going to be called gastric distension. And then I promise you, it's got to go somewhere. And if you with that patient long enough, it's either going to come up as a belch, come out as a fart. There's only two things the gas can move. And I promise you, if the patient is deceased and you're moving around and about 10 minutes later you hear, you will clear a room faster than you can imagine of some big, healthy individuals, and they think they big bad because they in EMS and fire. Promise you, they gonna clear that room. His bodies ain't supposed to make that. So again, we go mouth to mouth and mouth to mask. I'm not gonna teach you that because that is, it's just, we're gonna skipped it. So here's your bag valve mask. If nobody's ever seen one, you can make the same thing fit for a dog. I've only tubed and stuck dogs. I've only started IVs on horses, but I know that you can use the same thing for a dog. Take the tip off there. They make the little cone part that goes over for a dog, so you can still bag valve. You can still bag a dog or cat. Some fire departments do have those on their trucks just in case. I will tell you, I know what your new topic is going to be for the discussion, so I'm not going to dive off into that. But so a bag valve mask, it does not. So when we talk about a pop-off valve, so if you overly force the bag and you squeeze this too fast, it should pop off and come out this side valve right here. Some of them have selector valves, and it's called a PEEP valve, will push that extra pressure out. No matter how hard you push it, once this is made a good seal, it's going to force the extra air out because it's not needed. Some of them do not have pop-off valves, but I want to say that it's the mandate has changed, and now they have to put them starting, I think this year, was if it hasn't been before. You can, oh God, I forgot my chair was locked. Whew. You can provide 100% of oxygen between the supplemental oxygen tank hooked up to your bag valve mask and making a proper seal. So there's only one valve, there's only one way that it should be going, and that's into the body. So if you do a head tilt chin lift and you're by yourself and you're bagging them, you stop to do CPR and you come back to give your 2 rescue breaths, you have to make sure that you have adequate seal every single time. You're going to be woe out when it's over with. And I know how it says in Spirits EMT, you can provide adequate tidal volume. In time, you will learn that because you can look at your monitor as you're doing this and be like, oh, that does not look good. That looks like a normal tidal volume. And that will help you. It's not like something that can be taught. So we talked about gastric distension. We talked about gastric distension. Now we talk about that. So basics cannot transport these. So let's put it that way. That's going to be easy. But an automatic transport ventilator, it is a manually triggered device attached to a control box, but the patient has to be I don't even know how to put that. So they have, the ones that I've messed with, they have to be sedated and or intubated. So that is not something that a basic in Mississippi or in the lower states that I'm aware is going to transport. But see what it is. It's basically a transport ventilator. So you don't have to bag them. This ventilator works off of the supplemental oxygen tank in the truck, and it does it all for you once you intubate them. We talked about the CPAP. This is a nose mask for CPAP. They don't all look like that anymore. I have this small one that just fits over my nose. really hard to talk if somebody talks to you. But CPAP is to help with sleep apnea, or people that quit breathing in their sleep. I quit breathing 96 times in an hour. That was kind of important that I started breathing again. We talked about, so it's a continuous pressure. That's what it stands for, continuous pressure, positive airway pressure. It does push more oxygen across the alveolar membrane, but it also prevents you from, they can have CPAPs that do full mask, nose. Basically what it is to force air in you if you continue to stop breathing, and it's the reflex that you get from the medulla to to breathe again. I've caught myself multiple times just gasping because of your mouth falls open. You know, you just get sleep, you go deep sleep, and your mouth's all dry because it's been blowing oxygen all because your mouth's been so open. So we just need to know about CPAPs. We do have CPAPs on the trucks, but they function differently and at a different pressure rating than you will see versus home and EMS CPAP, because ours is BiPAP. So the functionality is the same, but you really just won't be transporting a CPAP where somebody's sleeping in the back of your truck. So that's why we use them differently. Let's skip that one. I'll that one. I don't know why that's there. So here is your stomas and your tracheostomy tubes. If they were to remove them, that's what they look like. It's a hole. They get nasty too. If they not well taken care of or they fresh, they get. I've had to suction out of them. It's gross. I try not to show them that I can't handle it, but there's times I'm just like, hey, look, you my basic partner, you can do this. I'm gonna drive. This happens. What's it say? Patients who have had a laryngotracheostomy have a permanent tracheostoma, and they'll cover them up when they talk, and they talk like this, and they move their fingers back and they breathe, and then they come back. Sometimes they have this little vibrating device that goes over it that makes the vocal cords move, and that's how they make their sound. Because they've had the surgery here and they've had to cut the vocal cords, so or throat cancer or something to that point like that. Let's go over this bullet right here. Neither the head tilt chin lift maneuver nor the jaw thrust maneuver is required because it's open. Just suction it and promise you it's open straight to the airway. If the patient has a tracheostomy tube, ventilate through the tube with a back valve mask. You can put it over there. You still got to do the EC method, but you really not hang on to the chin. You just want to create a firm pressure. And it is not like you were going to meet some resistance when you bag through it, but at the same time, it's not going to be like trying to ventilate somebody through a McDonald's straw. You can't, it's not going to work, but that's the only opening they got. You make it work. You can take off the top of the bag valve mask as long as this piece right here has this connector piece that goes over it. Not a lot of times you will see this open because their throat gets super, super dry through here and it can cause infections. So there's a little cap that goes over here. And I just want to show y'all so y'all understand what I'm talking about. Oh, come on. Hang on. So this piece right here comes off, and there's a little bitty part right there that fits right over that stoma. So you can ventilate them that way in this nice device. You can breathe for them. Then it's a less of a trying to breathe through a straw feeling. If you can't ventilate real well, there is resistance in there. Maybe there is some secretions inside the stoma that you may have to ventilate, or your partner may have to do that for you. And you will try. Y'all see this bullet right here? Never, ever will that happen to Chris Wiley. unless it's y'all's family member and y'all love them dearly and y'all have youngins, y'all feel right ahead. But don't do this. I don't know how else to say that no clearer. Clearing airway obstructions, obviously, if you don't remove it or do your best, they're going to go into respiratory failure. My child, as grateful as he is, decided to swallow a dime when he was 3 and it blocked his airway. I did the Heimlich maneuver on him. He spit it across the room. My in-laws were traumatized, and at the time, now I don't really care about the in-laws at the time because it's the ex. But it's kind of funny because the dime went flying across the room. But again, that can happen very easily, small toys. But again, if that didn't happen and he was in his room by himself, we would have never known and he could have died because of the airway obstruction. So be careful, especially with little kids. Always keep your eyes on them. Adults can be the same way. You know that their airway can be blocked by bulky food, maybe not chewing their food correctly, or somebody started on them while they're eating and they just clog their airway. So remove it the best that we can. We do have utensils in EMS that allows us to reach and grab something. Never, ever, ever, ever stick your digits in somebody's mouth. You only got 10 of them. Use a piece of metal to remove something. You have special forceps and all that to grab them out and move them. I like my digits. I think that they fit me well, so I don't want somebody else to eat them. So don't put your fingers in somebody's mouth. Again, we've talked about the tongue is the most common airway obstruction because it relaxes and it can block the airway. It's not going to get stuck in the airway. We've talked about that multiple times. Swelling of infection, allergic reactions will cause the airway to occlude. Repeated attempts to clear the airway could also be dangerous because you're going to cause trauma and the airway is going to start swelling. That's the reason why we have it's a written rule in some agencies that you don't rapid sequence intubate without another medic on scene, because if you miss the airway twice, you agitate it and it's going to cause it to start swelling. So it's always best if you try to intubate twice and you can't get it, you want to use a other airway device like a King Airway or there's a couple of other ones. We have Kings out here. I will show y'all Kings when we go into that portion. But those are some of the parts there. A mild airway obstruction, the patient can still breathe, but at the same time as they're not like you and I right now. I'm sure at 9:20 at night, some of y'all are like, oh my God, maybe if I have trouble breathing, he'll quit talking. But you'll hear that wheezing, the cough, that sick sound. Like when people have the crud, it's a lot of fluid, a lot of drainage, and phlegm can cause some airway exchange. Now, again, you're gonna want to continue to assess the airway, even on your good normal patient. Continue to assess it because you don't know at any point in time that mild airway obstruction become severe and go into respiratory distress to failure and all that. What's it say? Yes, you want to treat immediately like any other airway issues. Specifically, if you've ever asked them, here's the good one I like to ask. You feel like I feel like my throat's closing up. Has this happened before? Yes, it has. Have you ever been intubated multiple times? Your pucker factor goes, oh Lord, because this patient's probably going to be intubated and you only have 1 to maybe 2 chances to intubate them. So what you do from that point forward is very, very important. So if you walk in the door and you can already hear them making noise as they breathe, you're in trouble because they're going to close up on you. And you need to make sure that you're ready for that. So again, I'm going to encourage you in your EMS career, never, ever, ever walk into somebody's house without equipment in your hand. Not the monitor, because the monitor is not going to fix the airway obstruction, but your bag will. The tools that are in your BLS, ALS bag will help you through that process. But you always treat them immediately, no matter what. There's Fred having trouble breathing. Obviously, he's choking. You'll see that the universal sign right there for Fred, but you may start to notice the lips become a little cyanotic, and he's turning some paleness. Maybe you shouldn't eat them Doritos without asking somebody else if they want some. He would have helped, got some help. Severe airway obstruction, there is little to no air movement in there. That's what starts to become severe. If when you open the airway and attempt 2 ventilations following chest compressions, it is obvious if the airway is blocked because you meet resistance. So you know that something's blocking that. If there's no chest rise and fall after several attempts to ventilate, or if you feel resistance while ventilating, consider possibility of airway obstruction. You think? I mean, it's blocked. What you want me to do? Start your CPR. Chest compressions, attempt head tilt chin lift, maybe something that way. Continue to try, no matter what, to ventilate. Hopefully with some chest compressions, maybe the pressure inside the cavity can get right and can potentially blow that obstruction inside the cheek. And then you can rotate the head to the side and use some tools to get whatever the obstruction is out. So they tell you that you can use a finger sweep if it's something into the mouth. I'm not sticking my finger into my mouth, but you know, it's up to you. Abdominal thrust, if they haven't gone unconscious, is very also good, that you can get behind them, use that, create the cavity pressure of the abdomen to the upper airway and potentially force that out. Some of the residual air is present in the lungs, compressed upward, like I said, causing that object to expel. Dentals, so anytime that you know that there are dentures in somebody's mouth, or you just can tell that they're dentures, remove them so they won't be in your way and cause airway obstructions. Because I don't know how many times that you go there and you're popping teeth out and you're like, oh, their teeth aren't supposed to come out like that. But dentures are more and more common these days than you can imagine. Get them out of your way early so you're not fighting them in the long run. And now a tooth has come out of their denture and it's like, oh, Lord, maybe that went down. Not in my way. My bad. Whoops. So if you can see any type of removable devices in their mouth, remove them. Facial bleeding. Facial injuries are very porous. They're going to bleed a lot. They are very venous. There's blood. There's veins at the surface, so it's you know, guys, if y'all seen a guy shaving and they cut themselves, they bleed like a stuck pig. And then if you get a small laceration on a kid to their forehead, they're gonna bleed like a stuck pig too. So you gotta be ready for that. You need to have suction standby. If they are bleeding and it's on the face and you can keep it out of the airway, do what you got to do because you don't want them swallowing the blood. Because when they start swallowing blood, guess what's going to happen? It's got to go somewhere. It's going to come up. And it's gross. And then it smells when they swallow blood. Plus vomit stinks anyway. But control that bleeding as much as you can. Depending on where it's at, apply direct pressure so you can try to stop it. Here's some of a mnemonic. Be magic. Perform bag mask pre-oxygenation. Evaluate the airway with difficulties. Manipulate the patient. Attempt first pass intubation. GI use a supraglottic airway if unable to intubate. And C, confirm successful intubation, correct issues. Now, from M down, you guys can do. You can do the oral, and you can also do the nasal. That's about it. You can't intubate. But if you can, and you can, if you do a head tilt chin lift and the patient starts breathing, but if you let go to do something else, guess what? We still kind of doing a head tilt chin lift, and your partner have to do everything else, unless you just change out. So be careful about that. Airway obstructions are very common, but so I think this is what majority of you guys want for tonight. Here is your class code, your attendance. I am going to type that in the chat at the bottom. So make sure you write that down, jot that code, screenshot it, do something, and that is your code for this evening. Does anyone have any questions, concerns? I don't really want to know if y'all got problems because I can't answer them all. But I will talk to you if you got any issues. Here's your code. Let me say that again. G10 GTN88. GTN88. All capital letters. If nobody has questions, y'all have a wonderful evening. I'll stick around for a few minutes. If y'all have questions, concerns, or problems, talk to me. Y'all can direct message me, or we can get everybody out and have another session. Other than that, deuces, y'all. Peace out. Have a good night.
I have a question.
Talk to me.
I always have a question.
It's okay.
So with like the boot camp that's coming up, like I know Robert had done told me about a little bit about what we're going to be doing, but as far as like, are we just, I guess what I'm confused about is like with the sheets. Okay. So I printed them all out. I have them all printed out. So like on the boot camp days, are we supposed to like bring like our sheets and do like scenarios? I know he was telling me earlier about how we're gonna like do hands-on skills too, but I'm just like trying to figure out exactly what we're doing besides that. Is that the only
Yes,
thing?
it will be more of a teaching thing. We will make sure that you know your skills up until this point. We will teach you some of your skills. We will go through the point of making sure that you don't have no questions, concerns, problems on what's going on. We have to teach you to a certain point. So what we've done in the past is we do the boot camp at the end, and it's kind of put a lot of people behind. So what we want to try to do is do it in the beginning now and see where we go from there. Are we creating any what's the difference? Is doing it sooner than later more helpful, or should we wait to the end? So when we say that we want to, oh, what happened? We want to do it at the beginning. We want to split them up between the sessions, is because we can get you to the point to where when you're done, you get your rides done, you're not waiting anymore. If there's questions, we can answer them at this point. We can make these skill sheets seem like they're not as traumatic as they look. So with us doing the boot camps, you will be hands-on. You'll be doing skill sessions. You will be doing I can say I haven't been to the last two because I have been offshore the last two. So in the past, we've done all the skills. So this is the first one that we've done that we're splitting it up. So that's where I don't know exactly what's going to take place because I haven't got the agenda from Rob. And then Leah, I got your message. For the ones that haven't had CPR, we will actually be teaching CPR through this because of what it covers. So you will test out on your CPR portion at the same time. So you'll do like, make sure you know your chest compressions. Make sure you do your head tilt chin lift. You'll be doing a full patient assessment on your other students that show up. You may do it on an instructor as you go. Hold on. Forgot where I was at. So we're gonna teach you what you like up to this module. What is today? I don't even know what today is. I just go day by day.
Thursday,
So,
July 29th.
so today, I was gonna say it was July 8th, but so today's the 29th. So let's say boot camp starts tomorrow night. We will teach you up to that point backwards. So you're caught up to that point. So you'll go patient assessment. We'll show you airway. We'll make sure you know how to put the airway adjuncts in. We'll let you see the airway adjuncts because if you've never, I mean, in the vet clinic, you may have seen the oral adjuncts and you may know how to use the bag, but some of the ones in here may not have. So at that point, it's a teaching tool for everybody. Let's say you're moving further than everybody else. Great. Well, we may use you to help say, hey, look, let's say now we're going to open up another station. We're going to allow you to help us teach this part. So once you're competent, we want to make sure we use the acronym see one, do one, teach one. I want you to see us use it. Now I want you to do it. Now teach me how to do it correctly. And that way you grasp things. By the time you see it, do it, and teach it, we're able to help you with instructions to get you to the point to where you're like, I'm ready to teach this adjunct part. Let's do this. As you can tell, I sit here and wave my hands all night there, and y'all don't see that, but that's kind of a distraction. That's why I turned the screen off because I'm like, up in here like that. So that's how the boot camps normally run, is to get you ready to move forward.
I guess because I know that you've been saying
You don't
that
like having the unknown, do you?
Yeah, I don't.
Now that I know that, I won't tell you anything.
Oh, please do. I like to plan and be prepared. I know that there's gonna be you don't know what's gonna happen. I mean, that's part of the reason why I like the veterinary, emergency medicine aspect, because it's so fast paced and you gotta hurry up and treat your patient and make sure they don't die.
Welcome to EMS.
Yeah, and so but I'm just like with the sheets or whatever, I keep going back to them because I'm like, are we going to use them? Because, with this point system, and I know you were
Yes,
talking about earlier.
you have to, on the final skill stations, every skill that we go over and you learn throughout this entire class, National Registry will test you on those sheets.
Okay.
It's either pass or fail. That's your only two. Not like, oh, well, let's do a redo. No, that's why I'm telling y'all, memorize these sheets because we will do it at a boot camp to where it is a final skills checkoff station. And that's it. It's either pass or fail. But we will make sure that all of y'all are ready before we allow you to go to National Skills Checkoff Station. We're going to set you up for success. We're not going to set you up for failure. I know that there's a couple of boot camps. I don't even have them written down. That's how I know about it about 2 weeks out that I will be home for. I don't know when they are, what they are, to be honest. I know this is sad. I'm the coordinator, the EMS coordinator for our program. But with me being gone so much and all that, I don't keep up with that. Rob tells me, hey, I need you here because he knows I'm home. And I'm like, oh, all right, I guess I'm going to Southwest Arkansas, So the closer we get to it, I'm actually planning on putting those in the schedule on Navigate so that everybody can see those and populate far enough in advance. I know you'll have them already, but it'll be in Navigate also so we can all see it.
I have a question, Chris.
Yes, talk to me.
So the National Registry, so we have to do the skills plus the knowledge part? 2 parts.
Very correct, though. It is a hands-on and a skill. It is hands-on and mental test. You have to take a computer-based test.
How many questions that max with their computer test?
Well, so here's how National Registry works. 250 questions is max. It can stop you at 75. It is a progressive test. So if you're doing really, really good and you notice the questions are progressively getting harder and harder, you're doing fantastic. If they get real hard and then they get stupid, you messed up somewhere. If I know a guy, I was the last one in Mississippi to take a written test. That tells you how old I've done this. He took the computer-based testing. They shut him off at 74 questions. He was like, oh, Jesus, I failed. I'm done. He passed it because he got everything right and they shut him off. So if you've made it that far and the computer shut you off, it's a skill-based test. So it depends on how good you do. They can shut you off at 100 because you've met the quality that they feel that you're good.
Okay.
To answer your question.
Yeah, and then for us next week, we just show up at the facility and just let them know, hey, we're here with
Show up with an open mind. Be ready to enjoy yourself. Rob's a super cool dude. I don't even know if he's going to be at all of them or some of our other remote instructors are going to be, but I can promise you for the ones that make it with Rob, phenomenal dude. Even I knew Rob before I worked for Rob. So at the same time as I value our friendship more than I do our business partnership, but he's a very knowledgeable guy. I hope one day y'all can meet Brandon also. He's our other instructor for the basic side. Super cool folks. I think you got the best instructor. That's just personal appearance, but I think y'all are gonna really enjoy when y'all go to these boot camps and y'all get to meet Rob and how just energetic and how easy he is to get to teach you guys.
So Rob is going to be at the one in Louisiana, right?
I don't want to lie to you, but I'm pretty sure you're right.
Okay. Okay.
I don't want to lie to you because that ain't fair, but Rob, I know he's on the road today heading back to his home, and he was in South Mississippi and he lives way up north. So that's why he couldn't teach for me earlier when I was running a little late. How's that?
All right.
Anybody else?
Nope. Or I'm done. All right.
Oh, you sure?
Yes, I'm sure. I'm done for tonight.
All right, listen, y'all have a wonderful evening. I'm actually gonna take a shower and go to bed. 4 o'clock's coming early in the morning. Y'all have a wonderful evening, and it was great talking to y'all. Please let me know if I didn't answer y'all's questions. Hit me up on Discord or email me, and we will work this out.
All right. Have a good night.
Good night, everybody.